Welcome back to The Explainer. Today we're diving deep into a really challenging bug, Abiotrophia defectiva. All the info you're about to see was pulled together using a Gemini deep search, and the visuals come to us from Microbe Canvas.
So let's kick things off with a classic clinical mystery, one that I'm sure many of you in the lab have run into. You get a blood culture bottle that flags positive, but when you go to subculture it, you get nothing, again and again. For any sharp microbiologist, that scenario should set off alarm bells for one particular culprit, the incredibly fussy, nutritionally demanding bacterium Abiotrophia defectiva.
All right, here's our game plan. We're going to follow a classic bench-to-bedside flow, connecting what we see in the lab directly to how it impacts the patient and their treatment. Okay, let's dive right in. To really get a handle on Abiotrophia defectiva, you first have to appreciate its complicated family history. It's a story that really mirrors how our understanding in microbiology has evolved over time. This timeline just captures its identity crisis perfectly. Way back in '61, it was just given a description based on its behavior, nutritionally variant streptococci, or NVS. It took until 1995, with the advent of tools like 16S-rRNA gene sequencing, for it to get its own genus, Abiotrophia, which literally means life nutrition deficiency, before it was finally separated from its close relative, Granulogatella, in 2000. All right, let's head over to the bench. This is where things get really interesting for us as microbiologists, because this bug's unique dietary needs make spotting it a real but fascinating challenge. So, right out of the gate, this organism tries to throw you off. The gram stain, it's all over the place. You're not going to see those nice, neat chains you expect from a strep. Instead, you get this wild pleomorphism, all sorts of shapes, like little rods, swollen cells, and it might not even stain consistently. It's so easy to dismiss it as a contaminant. And that brings us to the absolute key to understanding this bug. It's a picky eater. It's nutritionally dependent. It needs a helper to provide the nutrients it can't make for itself, which leads to this beautiful, classic phenomenon we call satellitism. So how do you actually prove this in the lab? It's a classic test. You take your blood agar plate with the suspect organism and you streak a single line of a helper, like Staphylococcus aureus, right across it. The Staphylococcus aureus then goes to work, lysing the red blood cells and releasing that sweet, sweet pyridoxal. That's vitamin B6 that Abiotrophia defectiva is craving. And voila, you get these tiny little satellite colonies popping up right alongside the helper streak. Okay, but what if you need to tell it apart from its close cousin, Granulogatella? That's where the biochem comes in. And really, it boils down to this very specific combination. While they might both be PR positive, the real tell for Abiotrophia defectiva is that it's positive for alpha-galactosidase and negative for beta-glucuronidase. Now, of course, in the modern lab, we've got some heavy hitters that make this way easier. MALDI-TOF is an absolute game changer, giving you a rapid ID right from the colony. But for those really tough cases, when you're dealing with a cultured negative sample directly from something like a heart valve, 16S rRNA sequencing is still the undisputed gold standard. So, we've identified it in the lab. Now let's follow that result to the patient's bedside and talk about the real-world damage this organism can do once it gets out of its normal home in the mouse and into the bloodstream. You might not see this bug causing bacteremia every day, but when you do, you have to take it very, very seriously. Because historically, this group of organisms accounts for up to 6% of all streptococcal infective endocarditis cases. And as we know, that is a devastating infection. And when it causes endocarditis, it is absolutely brutal. We're talking a really severe clinical course. There's a high risk of embolic events. It chews through heart valves, leading to heart failure. And if you don't hit it hard with the right antibiotic combo, you're looking at a high rate of treatment failure and relapse. Okay, this brings us to what is honestly the trickiest part of the whole story. How do you actually treat it? Because this is one of those areas where the experts, they don't always see eye to eye. First things first, you've got to know what won't work. It's just naturally resistant to sulfonamides, so something like cotrimoxazole is off the table. It also tends to have reduced susceptibility to penicillin, and what's really important for those of us in the lab, EU-CAST. They tell us there are no specific breakpoints, so we have to be cautious and use the non-species related ones. And here it is, the big debate in a nutshell. What do you do about gentamicin for synergy? You have two major schools of thought.
In the US, the American Heart Association says you need it for the full 4 to 6 week course, basically treating it like an enterococcus. But in Europe, the ESC is a bit more cautious, recommending it for at least the first 2 weeks, trying to balance that killing power with the risk of toxicity. This table lays it all out beautifully. You can see the aggressive, treat it like enterococcus philosophy from the AHA. Then you have the more nuanced approach from the ESC in their 2023 guidelines. And what's really interesting is the Dutch swab guidelines, which basically say, look, this is so rare here, we don't have enough data to give specific advice.
Now, what about kids? It's rare, thank goodness, usually seen in kids who have underlying heart conditions. But the principles of combination therapy are exactly the same. The key word here, though, is meticulous. Everything has to be strictly dosed by weight with careful drug monitoring. All right, let's wrap this up by talking about how we can prevent some of these infections from happening in the first place and really lock in those key takeaways for our clinical practice. This is so important for infection control. We're talking about iatrogenic meningitis, infections caused by a medical procedure. In cases have been directly traced back to the oral flora of healthcare workers during spinal procedures. The cause? An unmasked provider. That is why wearing a surgical mask during a lumbar puncture isn't just a good idea. It is a mandatory, non-negotiable standard of care. You know, this quote just nails it. It perfectly captures the essence of dealing with Abiotrophia defecta. A good outcome for the patient is completely dependent on that teamwork, that partnership between a really sharp microbiologist and a well-informed clinician. So, if you remember nothing else from today, remember these 4 things. 1. Think Abiotrophia defectiva in any case of culture-negative endocarditis. 2. Remember it's picky and needs special media or a helper for that classic satellitism test. 3. Treat it aggressively with synergistic combination therapy. And 4. Always mask up for spinal procedures. And just so you know where all this information came from, we've pulled together all the source documents into one notebook. If you want to go read the primary literature for yourself, you can find the link for that right in the description. Hey, if you found this deep dive helpful, we would love for you to subscribe for more explainers just like this one. And please let us know what you think in the comments. Your questions and your feedback are huge for us. Thanks so much for watching.